Good afternoon. So it's going to be a quick talk. The indications for plating in pediatric femur fractures are very less, but we do see fair number of complications such as malunion, loss of reductions, unstable fixation, implant failure, and the distal femur going into valgus deformity. So let's look at some of the cases. 8-year-old boy presented with this picture somewhere else. Then that fracture was fixed, and 3 months down the line, he presents with this picture. So now question is, what do we do? He also has a mid-shaft tibia and fibula fracture, and he sustained a undisplaced fracture in distal femur. So this fracture is in malunion, and at this age with valgus and apex anterior deformity, it does not remodel completely. So the other fracture was treated non-operatively. Then we gave him some time for about 9 months. Still, it did not remodel. It remained in valgus. So he underwent a varus osteotomy, and that was corrected. Another example, 9-year-old girl, a long oblique fracture, not a good indication for titanium elastic nail. So submuscular plating decision was made, and that was treated on fracture table. Intraoperatively, everything went well, but the post-op X-ray showed this. The fracture table broke and the reduction was lost. And then the question is whether this is acceptable or what we should do. So the situation was discussed with parents. They were not ready for any kind of intervention at this point. So the fracture was protected with a custom molded splint, and patient was kept non-weight bearing. Fortunately, luckily at this time, it went on to heal well. That's how it looked at 7 weeks. That's how it looked at 11 weeks. Fortunately, there was no deformity. It healed well, but sometimes it may not be possible, and this may fall apart and may end up with problems. So lesson learned that this can happen, and one need to be prepared to overcome this situation. The last example of 14-year-old girl, which was treated with plating somewhere else and presented to me with this picture. She started walking early, and she never used any walker or crutches, and she was full weight bearing and ended with a fall and with a broken plate and femur which is in varus. Again, that needs to be revised, and she went on to heal well. So plating in children is uncommon, but if one needs to do, then yes, there are certain principles which we follow, and then that will avoid all the complications which we have seen. Another reported complication is distal femur varus. So studies have shown that if the femoral plate is within 2 centimeters from the distal femoral physis, then the distal femur goes into valgus deformity. So here recommendation is to stay away at least 2 or 3 centimeters away from the distal femoral physis to prevent this. And that's a picture from this article published in Journal of Orthopaedic Trauma. You can see that it has clearly gone into valgus, and also you can see the stress shielding. So femur plating in a child is not as innocuous as it looks. So if one has to do femur plating in a child, certain principles which I would follow, that avoid malreduction. If required, do mini open or open approach. It's okay to do a correct plating by open approach. If stability is in doubt, protect or consider revision surgery at an early stage. Stay at least 2 centimeters away from the distal femoral physis. If the anatomy of the fracture doesn't allow that, then consider early implant removal if you are too close to the distal femoral physis. And always avoid premature weight bearing and protect the fracture. Thank you.